On March 23, 2020, the United Kingdom Prime Minister Boris Johnson announced a complete COVID-19 lockdown of the UK. He provided compelling reasons for that decision. Without a huge national effort to halt the growth of this virus, he said, there will be a moment when no health service in the world could possibly cope, because there won't be enough ventilators, enough intensive care beds, enough doctors and nurses. How did he know this? He knew, or thought he knew, because those were the predictions made by Neil Ferguson and his team at Imperial College London. The predictions were made in a report, Report 9, that used a model to forecast the outcomes of a COVID-19 pandemic. We now provide a detailed look at that forecasting model and Report 9. The impact of non-pharmaceutical interventions to reduce COVID-19 mortality and healthcare demand. The report identifies two fundamental strategies that could be adopted to fight the pandemic. Mitigation, which focuses on slowing but not necessarily stopping epidemic spread. Reducing peak healthcare demand while protecting those most at risk of severe disease. The other strategy being suppression, which aims to reverse epidemic growth, reducing case numbers to low levels and maintaining that situation indefinitely. Before examining those two options, Report 9 establishes a baseline forecast based on what if we did nothing? How would the pandemic play out in such a circumstance? The two options of mitigation and suppression are then compared to this baseline. For this unmitigated option, the report says, for an uncontrolled epidemic, we predict critical care bed capacity would be exceeded as early as the second week in April 2020. That would be only 3 or 4 weeks away. The report forecast that the pandemic would overrun the UK National Health Service with an eventual peak in ICU or critical care bed demand that is over 30 times greater than the maximum supply in both countries, that's the UK and USA. The report was distributed to both governments. And if the UK government took no action, the UK might face more than 500,000 deaths. The model actually forecast 510,000 deaths. The deaths would reach a peak around the last week of May 2020. This was just 2 months away. This forecast is both alarming and incredible for several reasons. But a very pertinent question occurs. If 510,000 people were to die of COVID-19 in the UK, how many people would be infected with COVID-19 over the same period? To answer that question, we turn to a crucial piece of data known as the IFR, the infection fatality ratio, which is a metric that quantifies the likelihood of an individual dying once infected with a pathogen, in this case COVID-19. As noted in this paper by The Lancet, the IFR is also a crucial parameter in COVID-19 dynamic transmission models, such as the model used in Report 9. The World Health Organization agrees and provides this simple calculation. The IFR expressed as a percentage equals the number of deaths divided by the number of infected times 100. We can now use this calculation to determine the number of people that the Report 9 model forecast would be infected in the UK. We know the number of deaths forecast, 510,000. But what was the IFR used in the model? The estimate of 0.9% was used. This study by The Lancet, published February 2022, shows that only Peru exceeded 0.9% at that time. But that was the estimate used in the model. So we plug that into the calculation to arrive at the number of infected individuals. That number in the UK forecast by the models in round numbers is 56,700,000. That's 56 million people infected over a period of 3 to 4 months. It is more than 80% of the UK population. This percentage is confirmed in Report 9. We will critically examine this prediction later in the video, but for now we note that the baseline of Report 9 has been established. If the UK government took no preventative actions, there would be more than 500,000 deaths and greater than 56 million infections. And the NHS would be overrun as early as the second week in April. We now look at what Report 9 forecast if the UK government adopted an optimal mitigation strategy, not a strict lockdown. The optimal mitigation strategy forecast is based on doing various combinations of case isolation and household quarantine, case isolation, home quarantine and social distancing of those aged over 70 and closing schools and universities. This graph shows the effect of each action in comparison with the black coloured baseline, do nothing. In essence, the more actions taken, the more the curve is flattened. Report 9 summarises by stating that in combination, this intervention strategy is predicted to reduce peak critical care demand by 2/3 and halve the number of deaths. That's about 255,000 deaths. However, it says, this optimal mitigation scenario would still result in an 8-fold higher peak demand on critical care beds over and above the available surge capacity in both Great Britain and the US. Therefore, it concludes mitigation is unlikely to be a viable option without overwhelming healthcare systems. The report goes on to advocate suppression, as it is likely necessary in countries able to implement the intensive controls required. So what is the suppression strategy? Suppression is a combination of case isolation, social distancing of the entire population, household quarantine, school and university closure. Not all are required, but all 4 interventions combined are predicted to have the largest effect on transmission. A chart is produced to show the predicted outcomes in terms of deaths and ICU beds depending on the interventions in place, the proportion of time with social distancing in place, and the R0 number. The R0 number is a mathematical term that indicates how contagious an infectious disease is. It's also referred to as the reproduction number. The value used are 2 or greater. We will return to this when we summarise. The report also makes the crucial assumption that suppression measures would be in place for a 5-month duration. Report 9 shows this chart that forecasts critical care beds occupied per 100,000 of population. For the 5-month period the measures are applied. You will notice the benefits of the measures are compared to the do-nothing black line option. It is the do-nothing curve that is being flattened. This is confirmed by Report 9. We must also notice that when the measures are relaxed after the 5-month period, there is no black line, but a similar peak of critical care beds was forecast to come during the UK's winter months. Another important point: the relevance of this chart is to a large extent moot, as the lockdown was in place for only around 3 months, not the specified 5 months. However, Report 9 concludes that the suppression intensive policy is predicted to result in a reduction in critical care requirements from a peak approximately 3 weeks after the interventions are introduced and a decline thereafter, while the intervention policies remain in place. Report 9 also contains several important caveats. It warns that the major challenge of suppression is that this type of intensive intervention package will need to be maintained until a vaccine becomes available. Potentially, they say, 18 months or more away. It also notes that while experience in China and South Korea show that suppression is possible in the short term, it remains to be seen whether it is possible long term. Very importantly, it asks whether the social and economic costs of the interventions adopted thus far can be reduced. This point is particularly relevant to the recommended strategy achieving a balanced approach and avoiding a situation where the impacts of the interventions outweigh their benefits. Finally, the report highlights that there are many uncertainties in policy effectiveness. We will now explore some of those uncertainties. The data that goes into a forecasting model needs to be as accurate as possible, otherwise garbage in, garbage out. The first area of uncertainty and threat to the integrity of the Report 9 forecasting model's input data is posed by the assumptions that Neil Ferguson's team needed to make. A small health warning: the next few minutes may seem a little tedious, but it is important that we get a reasonable understanding of the breadth and depth of the assumptions made. First, per capita contacts within schools were assumed to be double those elsewhere in order to reproduce the attack rates in children observed in past influenza pandemics. Approximately 1/3 of transmission occurs in the household, 1/3 in schools and workplaces, and the remaining third in the community. We assumed an incubation period of 5.1 days. Infectiousness is assumed to occur from 12 hours prior to the onset of symptoms for those that are symptomatic, and from 4.6 days after infection in those that are asymptomatic, with an infectiousness profile over time that results in a 6.5-day mean generation time. Based on fits to the early growth rate of the epidemic in Wuhan, we make a baseline assumption that R0 equals 2.4, but examine values between 2 and 2.6. We assume that symptomatic individuals are 50% more infectious than asymptomatic individuals. Individual infectiousness is assumed to be variable, described by a gamma distribution with mean 1 and shape parameter alpha equals 0.25. On recovery from infection, individuals are assumed to be immune to reinfection in the short term. Infection was assumed to be seeded in each country at an exponentially growing rate with a doubling time of 5 days from early January 2020, with the rate of seeding being calibrated to give local epidemics which reproduce the observed cumulative numbers of deaths in Great Britain or the US seen by 14th of March 2020. Analysis of data from China, as well as data from those returning on repatriation flights, suggest that 40 to 50% of infections were not identified as cases. We therefore assume that 2/3 of cases are sufficiently symptomatic to self-isolate, if required by policy, within 1 day of symptom onset, and a mean delay from onset of symptoms to hospitalization of 5 days. The age-stratified proportion of infections that require hospitalization and the infection fatality ratio were obtained from an analysis of a subset of cases from China. These estimates were corrected for non-uniform attack rates by age, and when applied to the Great Britain population resulted in an IFR of 0.9%, with 4.4% of the infections hospitalized. We assume that 30% of those that are hospitalized will require critical care based on early reports from COVID-19 cases in the UK, China and Italy. Based on expert clinical opinion, we assume that 50% of those in critical care will die, and an age-dependent proportion of those that do not require critical care die, calculated to match the overall IFR. We calculate bed demand numbers assuming a total duration of stay in hospital of 8 days if critical care is not required, and 16 days with 10 days in ICU if critical care is required. With 30% of hospitalized cases requiring critical care, we obtain an overall mean duration of hospitalization of 10.4 days. When examining mitigation strategies, we assume policies are enforced for 3 months, other than social distancing of those over the age of 70, which is assumed to remain in place for 1 month longer. Suppression strategies are assumed to be in place for 5 months or longer. And finally, there is this list of assumptions made for each type of intervention. We come to the obvious conclusion that if the assumptions are incorrect, then the forecasts will be incorrect. Or more subtly, assumptions in, assumptions out. Before concluding, we will now examine 2 further items of uncertain data that lie at the core of the Report 9 forecasting model: the IFR estimate and the proportion of the population predicted to be infected with COVID-19. First, the IFR estimate. Report 9 states that the infection fatality ratio was obtained from an analysis of a subset of cases from China. These estimates were then adjusted to fit the UK population. Total confirmed cases in China on the report date of March 16, 2020 was 81,000, and the number of deaths 3,213. This is out of a population of 1.4 billion. The report considered only a subset of this data. So our initial observation is that the estimate of IFR equals 0.9 was not, and of course could not at that time, be based on a large data set. We now turn our attention to the IFR calculation itself and first look at the number of infected individuals. In May 2020, during the first lockdown, Dr. John Lee wrote that the number infected is unknown. We only know about those with a positive test. Report 9 confirms this with the uncertain suggestion that 40 to 50% of the infections were not identified as cases. So, the number of infected individuals is very uncertain. What about the number of deaths from COVID-19 in the IFR calculation? Again, in May 2020, Dr. John Lee wrote that COVID-19 deaths are a substantial overestimate. The way COVID-19 deaths were being recorded did not take into account comorbidity. He pointed out that there is a big difference between COVID-19 causing death and COVID-19 being found in someone who died of other causes. In fact, the very same topic had been raised by Dr. Fauci in March 2020, when he was questioned about what appeared to be a high number of young people affected by COVID-19 in Italy and elsewhere in Europe. He stated that you need to be sure it isn't just driven by the fact that they have underlying conditions. He stated, because we know that with underlying conditions all bets are off. We will now demonstrate just how uncertain this problem is. We start by looking at the number of deaths where COVID-19 was the only cause mentioned on the death certificate from 1st of February 2020 to 31st of December 2021. This chart is from the UK Office of National Statistics. It shows an extremely low number of COVID-19 only cause deaths. A total of just 6,183 such deaths from February 2020 to December 2021. This can be taken as one extreme for the estimate of the number of deaths. Another extreme is shown in the Worldometer website, where total COVID-19 deaths is 161,000. The UK government also used this number, but add further confusion by adding another category, deaths with COVID-19, on the death certificate. And this shows 182,000. The Office of National Statistics supply a breakdown of deaths, and this breakdown lies midway between these extremes. They put the number of deaths due to COVID-19 as 73,000, and the number involving COVID-19 as 81,000. This shows a rough 47% of the total to be due to COVID-19, and can be thought of as the median for COVID-19 deaths. Based on this analysis, it can be seen that COVID-19 deaths could well be a substantial overestimate. And in combination with our earlier finding that COVID-19 infections are a vast underestimate, it is evident that both these integral parts of the IFR calculation are uncertain, and therefore the infection fatality ratio itself must be uncertain. And it follows that if the IFR is uncertain, then the Report 9 forecasts are themselves uncertain. Before summarising, we will look at the prediction that 81% of the UK population would be infected within 3 to 4 months. This is the exact quote from Report 9. Report 9 draws our attention to the Spanish flu pandemic of 1918 to 1919. We therefore compare the 81% forecast infection rate with that of the Spanish flu. The US CDC estimates that 1/3 of the world's population became infected with this virus. This knowledge must make the prediction of 81% of the UK population infected very, very questionable and extremely uncertain. If we return to this calculation and change the 81% to 33%, the number of infected individuals in the UK becomes 18,900,000, and keeping the IFR at 0.9, the number of deaths drops from 510,000 to 170,000, which probably coincidentally is a pretty close to the all-inclusive number of COVID-19 deaths published by Worldometer. And again, perhaps coincidentally, the number of infections at 18,900,000 is pretty close to the Worldometer number of cases, early March 2022. That brings us to the end of this section, which examined the many uncertainties that were contained within Report 9. and the advice given to the UK government. We now briefly critique Report 9 and the forecasting model, and then we go into more detail on the overall balance and management of the UK government's response. First, Report 9 and the forecasting model, and the criticism of the model that it got things wrong due to a software error. There have been reviews of the software code, not all complimentary, but this was not a software problem. Those interested can study the code on the displayed link. This criticism by MP Bob Seely is much more pertinent. The conclusions of Report 9 were based on so little potentially flawed data. As of March 16, 2020, there were a limited number of cases and deaths spread over 146 countries. The IFR was based on just a subset of cases from China. Another fundamental piece of data was based only on fits to the early growth rate of the epidemic in Wuhan. This is the R0 or reproduction number. It tells you the average number of people who will contract a contagious disease from one person with that disease. Thus, if R0 for COVID-19 equals 2.4, then a person who has COVID-19 will transmit it to an average of 2.4 other people. It is this value of R0 equals 2.4 that gives the infection estimate of 81% of the UK population. But it was based only on a small and early set of data. We therefore agree with MP Bob Seely. The input data set was small and was potentially flawed due to the uncertainty around the assumptions. We also strongly think that the do-nothing option was a worst-case scenario. A sliding range of do-nothing scenarios could have been presented. For example, 30% of the population being infected over a longer period. It is the curve on this worst-case scenario that was being flattened and which alarmed governments. We note that the report published caveats such as not knowing the social and economic effects of suppression, and that it is not at all certain that suppression would succeed long term. But we still conclude that although the report did contain significant caveats, these caveats and warnings were not strongly enough expressed. Finally, and probably the most significant criticism we have is that Report 9 states that epidemic suppression is the only viable strategy at the current time. We strongly feel, as do others, that the strict differentiation between mitigation and suppression was simplistic. A sliding range of options exist, from do-nothing through mitigation up to strict suppression and lockdown. The recommendation for suppression was thus far too strong. That completes our critique of the Report 9 and its forecasting model. The consequences of the report and its recommendations for a suppression lockdown were enormous. The BROWNSTONE Institute summarises, this moment in history kicked off a radical upheaval of almost all aspects of economics, law and public health, creating a painful labour shortage, inspiring unprecedented levels of public debt accumulation, enabling a monetary inflation without modern precedent, and creating strife, division, and general anger and demoralisation among the public. A later video on this channel will examine whether this was a planned start of the Great Reset. This community combines the topics of climate change, COVID-19 and the New World Order. If you would like to join our community, you can find us on locals.com. The New World Order. This link will take you directly to our site.